the whole colony. After that, what happens, they migrate to the sub-epithelial space. So you have mucosa, you have epithelium, columnar epithelium, then you have the basal membrane, sub-epithelial space. And so there, what happens, they release a lot of toxin, and they release also parts of the membrane. This part of the membrane will be delivered eventually to the antigen presenting cells, and the immune system will produce then the immunoglobulins M. Now, these immunoglobulins M are playing a very bad role in terms of the pathogenesis of the meningococcemia, because they're not really killing the bacteria, they're going to kill own cells. But I'll talk about this just in a bit. And then the hyperproduction of the endotoxin, of course, because the bacteria dies and is going to release. This endotoxin eventually will end up killing the endothelium of the vessels, and this the endothelium, since the vascular endothelium, when it dies, it creates a space for the leakage of blood. Okay, so it's the small hemorrhages. Now these small hemorrhages, of course, your body, and we call it vasculitis. Okay, the inflammation and the injury of the vessel. The vasculitis, of course, the body tries to close the leakage of blood, leading to the thrombosis. And this thrombosis, the little thrombi, it leads to the intravascular, disseminated intravascular coagulation syndrome. I'll talk about this in a little bit. Okay, so here's going to be a video. Unfortunately, this software, you've seen this video on YouTube, haven't you? Did you watch it? Okay, very good. Those who didn't, it's in this presentation. Well, it's funny. Well, I'm not a painter. I'm not an artist. So if I would be doing that, it will be total crap. But I'm going to use the drawings of this guy and just going to explain some of the things to you. So you can see here that wait, he's too fast. Stop it. Okay. So you can see here that these are the common species that cause the meningitis. That's not what I really want. How can I? Okay. I can't stop the video where I want, unfortunately. Anyway, all right. What? I can't hear you. Okay. So what I want you to see on this video, actually, I'm trying to rewind, but it doesn't work. So basically, the bacteria gets through the nasopharynx. It gets into the bloodstream. Through the bloodstream, eventually, it will lead to there's a mastoiditis, basal sulfite, whatever. It's too blah 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 talking. Okay, few of the things that you need to know right here is that it gets into the venous system, not arterial, the venous system. You remember that you have the venous sinuses close to the arachnoid tissue, right? Yeah, so you have colonization, evasion, immune evasion, that's hiding from the immune system, and meningeal evasion. It means invasion into the meninges of the brain. So there's the epithelium. This is the mucosa, the epithelium. Oh, this is just too long. Can I go from IgM participation again because voice gone? Yes, I'll talk about it once I move on to the complement. So this is the vessel, and basically what happens, the bacteria comes through the mucosa, and then it colonizes right here in the epithelium. From the epithelium, it gets into the subepithelial or interstitial level over here from where it gets into the bloodstream. And this guy is just so long. I wish I could draw like him. Okay, so what happens next? Basically, through the bloodstream, it gets into the it gets into the venous sinuses, and then what happens? Funny, your immune system actually plays on the hand of the bacteria, because the supportive cells of the brain, which are the astrocytes and the glial cells, they will catch the bacteria. They will catch the bacteria from the sinus and drag it inside into the brain tissue, and that's what will actually cause will basically help the bacteria to evade the brain tissue. The brain tissue. Now, if you remember from the biochemistry, basically the brain tissue, it's the one that consumes the biggest amount of sugar, the glucose in the body. Loves sugar, so it's like heaven, you know. It's just end up in heaven. So they start multiplying, they start reproducing like hell, just because they have the very favorable environment. All right, thank you. Finally, this guy got to the place where I wanted. So right here, you can see that these are the ventricles where the CSF is being produced, and these are the venous sinuses right here. And then below the venous sinuses, you have the arachnoidea, which the arachnoid matter, and arachnoid matter has enormous amount of vessels. So again, through those vessels, basically you have the bacteria reaching from everywhere. And then this is how it gets into the subarachnoid space, and that's why we can see it in the CSF, okay? So I hope that this pathogenesis, that you got through this and it was not that difficult for you to get it. Yes or no? You understand this part? Okay, everyone else should just, you know, somehow let me know in the chat whether you understand it or not, because I can only see 2 people, and yeah, unfortunately. Okay, good. All right, then let's skip the video then. So you have the colonization, then you have the blah 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 entering. Now here is what I want you to know: the bactericidal activity of the complement system is required for the clearance of the organism, usually, but not in this case, because bacteria has the protein 1. Remember this: the protein 1 is responsible. It's the factor of resistance, and it helps the bacteria to survive the complement. So what happens next? There's cross-reactivity. Basically, the complement starts attacking own tissues, everything that has the same. So let's say you had the bacteria that was killing the endothelium and ruining and causing the bleeding in certain spaces. Now the body is attacking own vessels and causing this. This is basically where the DICS come from, because you have the bombarding of the endothelium everywhere in the body, and the body is trying to stop that by clotting, but eventually you have the exhaustion of the clotting factors. There are no clotting factors anymore. So when that happens, you have leakage of blood everywhere. So that's how you may have the patient end up with the hemorrhage inside the brain. Who knows? Okay. So laboratory characteristics. I think we discussed this a bit, right? So I told you about the CSF microscopy, and then, well, you do the test there, oxidase positive. What's that? You're showing me something, but I can't see it. So if you want to say something, you text. Oh, you've written that down. I understand. Okay, good. Okay, so now the lumbar puncture. So you have the L3 and L4. You can do it in 2 ways. One, it's when the person is sitting down, and then you put the forehead, on the hands, like that, or else you can lay the patient down in the supine position on the bed and then do the puncture. Now, here's the thing. So some people will tell you that you need to have 90 degrees. Now, I've seen this, and I think this guy is teaching, I'm not sure if he's teaching the foreign students though. He's teaching anesthesiology, but I think Ukrainians. So what he does that with the angle of 45. And then not just 45 towards the surface, it's also angulated from the sidewise. I have no idea why he does that, but trust me, he does that much faster and is more successful. So if you're interested in anesthesiology, you can either talk to this guy, whatever his name is. I'll tell you if I remember. But anyway, if not, you can also Google it and see various ways of the lumbar puncture. But what you want to do, the main thing is you want to go through the yellow ligament, okay? Not going further, because if you traumatize these nerves, the patient may be paralyzed. So you have to be cautious about that. So this is the milky look of the CSF. Why do you think this milky look is there? What makes it milky? Just your ideas in the chat. Carbs? Nope. Proteins. Very good. Yes, it's the protein. The protein which makes it so turbid. Plus, plus also you have the macrophages, which also contribute to the turbidity. All right, very good. So this is how the brain looks like. Yummy. So you can see the vascular congestion. They're thick. Okay, the vessels are thick. This is the this is basically the arachnoid matter. Okay, that's how it looks like. And you can also see pus along. So why is it? And this is how the CSF, the purine CSF, looks like. Okay. Okay, let's move on with that. So the rash, as I told you before, right? This is the pathogenesis rash. The pathogenesis rash, it has two pathways. Let me just go back a little bit. As when I told you in the nasopharynx, the bacteria gets into the bloodstream, right? So two ways it can cause the disease. It's either the meningococcal meningitis or meningococcemia, meningeal sepsis, or it's the combined form, both things together. So you may have the meningococcemia, the sepsis, without the meningitis, okay? So just make sure that you remember that. It's not necessarily that the patient will have stiff neck, Brzezinski-Kernig's, blah, 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 no, because it may be just the sepsis, okay? Now, by the sepsis, it means the hyperreactivity of the immune system that is trying to kill as much as possible of Neisseria. And you remember that it releases the LPS, the endotoxin, and endotoxin kills the vessels as well as, plus what happens, so the distal parts of the body, usually that's the fingers, ears, the nose. What happens when the small vessels get occluded by those thrombi? Remember, the body tries to stop bleeding in various places, but then those thrombi may get loosened and leave that place. And then when they obturate some vessels, that area goes under necrosis. So all of these areas, all of this rash, that's the necrotized tissue, okay? Which means that after some time, this tissue will be peeled off, just like a burn or an injury, right? When you hit yourself, when it's like a bruise, the bruise gets reabsorbed, it gets green in color, and it leaves the place. This place will become like a hole, like a lesion, like an ulcer, okay? It will never heal. Very often in children, you can also note that in children, most typical localization of the rash, that's the big joints, knees, hips, and shoulders. Especially in the hips, and if there is a really massive leakage of blood, especially intra joints, then most often these children will be left without limbs because you have to go for amputation. Okay. All right. So what do? Number one thing, you take a glass, or you can do it with your finger. You press. If it's vasculitis, it will disappear. If it's meningitis, it will remain there. Okay, a simple test. Also, often the pathogenesis rash may lead to the formation of bullae, hemorrhagic bullae. That's blood underneath the skin. Okay, in these cases, imagine, so you have the high intoxication because of the bacteria. You have increasingly enormous intoxication because of the immune system killing the bacteria. The intoxication is also increased because of the cytokines, because of the interferons, interleukins, because of the dying cells, because of the complement proteins, and also this tissue is also dying because it's necrotized. So what you want to do, you also want to make sure that if there is accumulation of blood, sometimes you want to drain that, and you want to make sure there's no development of secondary sepsis. Because the woman that died recently, and that's what I asked you to remind me in class, she died not because of the Neisseria meningitis, she died because of the Staphylococcus aureus. She had a lesion on her shoulder and on her chest, and then eventually this bacteria got into the bloodstream, and those people who watch Grey's Anatomy and House, you know, flesh-eating bacteria, which is MRSA, the methicillin-resistant Staphylococcus aureus, it's a nosocomial infection. So she died. She died within 3 days because of the sepsis. Okay, so complement, I promised you that. So this is the antigen, this is the bacteria, okay? And then you have the antibodies. This is the classical pathway. And I think that in the 5th year, you should be having immunology. So I really pray to God that the teacher will do her job and teach you these principles. But anyway, so you have this protein right here, and it's called C2. So the C2 will cleave into C2A, C2B. Same thing from C2 to C4, okay, these fragments, they will then cleave more and more and more. It's basically decreasing the size of the protein by hydrolysis, okay? Hydrolysis means taking away the water, the H2O. And then eventually you will have the cleavage from C5 to C9. So, well, hold on a second. I'm going to try showing you how that works. So basically, it's just like you will have pens, okay? You put them around, and you will make a tube out of pens. So they will make a pore, and the cytoplasm will leak out from the cell. Do you understand? So out of these proteins, they will make, so these proteins, they will make a pore, and that pore will cause the leakage of the water. See this pore right here? The cell swells and bursts, okay? So basically, these complement proteins, they're circulating in the blood, and then let's say the antibodies, the IgMs that are formed towards the Neisseria meningitis, they will just collect them together and start killing your own cells. Okay. Now, so what is basically, yeah, right here you can see the bacteria, the constant sepsis, which means that the bacteria constantly reaches into the bloodstream, and then you have the pro-inflammatory cytokines, which will trigger the monocytes. The monocytes will release the tissue factor, okay, and cause the fibrin deposition. Fibrin, remember, it's the clotting factor, prothrombin and thrombin, okay? So all of them, they will create the microthrombi everywhere in the vessels. And then these microthrombi will travel around the bloodstream until they reach the small lumen where they cannot pass, creating the ischemia, necrosis of that area. Now, I want you to tell me what? Sorry, sir, we wish that you recorded this lecture because we missed a lot due to technical issues. I'm very sorry, I can't record it because otherwise I have to pay money. I'm not paying money for any software. Wish you please find a solution because it's not working anymore. Didn't quite understand the complement system. Okay, the complement system, that is a cascade of reactions at which the protein will go through certain conformation. The protein will change its structure. Eventually, this protein will create a, wait. Do I have any working pens over here? 1 second. Is it visible right here? So it's just like that, it will make a pore like this. But the proteins themselves, they are long. So they will look like this, and the cell membrane will be in the middle, okay? But inside it's hollow, there's nothing. So basically everything will come out of the cell. All the cytoplasm will, with nucleus, with the organelles. Okay, so that's why the cells will die. The viewer 42, is that clear, or should I try to find any other explanation on that? Whoever is viewer 42. Okay. Well, we don't have time for that. But if you want me to explain that again in class, just remind me, because I don't know who you are, but then, okay. So the DICS is clear, right? You understand the pathogenesis of disseminated intravascular coagulation. Okay, now, got it, that explains the bleeding. Good. Apart from that, what else what you need to know, that tell me, just type, what are the most highly vascularized organs in the human body? Hello? Heart, brain, kidney. Heart. Okay, I wouldn't really say that heart is that highly vascularized compared to kidneys. True. So it's kidneys and liver. Do you agree with me? Okay. So what you need to understand is this coagulation will also occur in those organs as well. That's why this will lead to kidney and to hepatic failure. Okay, and as you know, hepatic coma, this is something that is irreversible. People do not recover from hepatic failure, because hepatic failure leads to the hepatoencephalic coma, and that is basically the reason of death. But lungs, true, lungs are also highly vascularized. That's why meningococcemia can lead to hemorrhagic pneumonia. Basically, that is hemorrhagic infarctions into the lungs. And again, this is the necrotized tissue. The only thing you can do is just get rid of it, because there's no way you can recover those part of lungs. That's true. That's very good. So the other thing that I wanted to talk to you about is the kidneys. Kidneys get affected by DICS as well, which leads to, but it leads to carditis. So why don't heart? No. Endocarditis, the pathogenesis is totally different, Milap. Endocarditis is the complication. Basically, just like in group A, beta hemolytic streptococci, the scarlet fever, remember that. It has the M protein and it also produces these complements, which will lead to arthritis, endocarditis. Remember those things? Rheumatic fever, blah, blah, blah. Glands, true. Yeah, so the pathogenesis of endocarditis, it's mainly because of the complement, not because of the DICS. All right, so yeah, let's go back to the kidneys. Now, most common complication and most common reason of death, that is kidney failure, all right? So the number one thing that you see exactly, and I think I have taken some of you guys to see the kid in the intensive care unit, the child that actually died eventually because of the kidney failure, right? Because it's highly vascularized organ. So oliguria, this is something that you have to suspect, and this is something that you have to manage if you suspect the meningococcemia. Now, this is the pathophysiology of DICS. You have the stimulus, basically the trigger factor to initiate, and then you have or either it is the tissue destruction or endothelial injury. In our case, we have endothelial injury by endotoxin, which will initiate the factor activation, right? The thrombin generation. Prothrombin leads to the thrombin generation. Then what we have the two pathways. See, there's one: plasminogen activation, plasmin generation, clotting factor degradation. No more clotting factors, not enough, okay? Consumption of excessive amount of platelets, thrombocytopenia, bleeding. Is that clear? Good. Okay. Moving on. So physical examination, this is something that all of you always forget. Brudzinski sign. That's when you pull the head. It's not the neck rigidity. The neck rigidity, it's when you can't move the neck. Okay. These are the knuckle muscles, which will go to the trapezius muscle. So these muscles are stiff. Okay. Well, I also have a stiff neck in the morning, but that doesn't mean I have meningitis, right? So not always a stiff neck is a sign of meningitis. The Brudzinski neck, that means when you pull the neck down, the knees will also go up, okay? They will flex, involuntary flexion of the knees and hips. Why is it so? Where does it come from? It comes from the intracranial pressure, okay? Because the excessive amount of pressure, and then the body does not know how to react. So the generalized reaction of the body. You also have the kerning sign. Now you have the kerning sign when you flex the knee at 90 degrees, okay? At the supine position. So what happens? You can't do the extension of when you do the 90 degree right here. You can't extend the foot, okay? All right, so let's talk a little bit about the treatment. According to the guidelines of WHO, you will often see that the treatment is the penicillin-based. Okay, true, but there's a lot of allergic reactions to penicillin, so that's why we really try to avoid that. Chloramphenicol or cephalosporins are used as the alternative drug, okay? Okay, so according to the protocols, you can also see here that rifampin or rifampicin are used as a chemoprophylaxis. It is in the protocols, but we all know that rifampin and rifampicin are used for what? Tuberculosis. So that's why we want to leave it as a drug of choice for tuberculosis. Please, I know that you may be affected by the healthcare system once you go back home, and you will be demanded to use these kind of medicine for treatment of various diseases, including of non-complicated things. But please remember of the smart use of the antibiotics. Viewer 70, once again, please what? Like, you guys, you can't just say something because it doesn't make sense to me. What do you want me to repeat? Okay. I'll wait for you to answer. Meanwhile, I'll continue. There is also polyvalent vaccine, which contains the A, C, and Y and W135, and it's usually done under the age of 2. So you should remember that there is something like that. Now, serogroup B, it's used mainly in African countries, in sub-Saharan Africa, just as I told you before. All right. Hold on. All right, so here's the local Ukrainian protocol, and as you know, the Kroc agency, they love Ukrainian guidelines and everything. So that's why I'm giving you both the WHO and the Ukrainian ones. I think you can compare. It's not a big deal for you to. They're not much different. Okay, so what we do, and trust me, from my own experience, this is a good approach. So please note it down, please keep it somewhere. So on the pre-hospital stage, when you see the patient for the first time, of course, when you get a call as an emergency, they will tell you we have a patient with neck rigidity and headache and vomiting. So you should already know that you may be dealing with meningitis, or you may be dealing with subarachnoid hemorrhage. And that's up there at the beginning of my presentation. You have the comparative table to see the difference between them. So oxygen therapy, you do the oxygen therapy, okay, immediately at admission, before the admission on the pre-hospital stage. When you just see the patient at home, wherever it is, you provide the oxygen. Also, you need to ensure the respiratory passage. Well, this is the ABC that you were studying from emergency medicine and anesthesiology. I think the lady in the regional hospital does a very good job on teaching you the ABC. Okay, so also you should maintain and provide a reliable venous access. That means that you should provide the cannula for the, what was the reaction? Wait, hold on, I can't see. Airway, breathing, circulation. Yes, very good. Just cephalosporins. Yes, we better go for the cephalosporins as the drug of choice. So you should provide the venous access, because you should always remember that when we deal with the meningococcemia, it is a septic process which may lead to septic shock. Now, can someone tell me what is the sign of shock? Number one and main sign of shock. Just type, I will understand what you mean. What is shock? Unresponsive. No, it's not true. Perfusion. What do you mean by perfusion? Hypoxia, no oxygen. Nope. 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 Low BP, very good. Whoever is viewer 71, it's true. Low BP. And yes, very good. Viewer 5, it's the low BP. Basically, we have what is the lowest perfusion required for the kidneys to function? Not enough blood flow. 90. Nope, that's the wrong answer. Increased pulse. Nope, increased pulse, that's not a sign of shock. It's the sign of the adaptive function restriction. Okay. Restriction. Are you trying to type restriction? Okay, tell me what is the minimum, okay, what is the minimum pulse for the kidneys to function? 60. Okay, yeah, 65 actually. So if the systolic is below 60, less O2 to blood. Okay, never mind. So yeah, if the systolic pressure drops below 60, that's when the kidneys, the perfusion in the kidneys stops, so there's no filtration of the primary urine. That's why you need to maintain the reliable venous access, and also you need to provide the isotonic saline solutions. But you need to always remember one thing, because this is a very typical mistake of a lot of doctors. They provide saline solution. Why? Because there is intoxication, there is sepsis, right? So you need to provide, you need to clear up the blood. The only way to clear it up is to filter it. But guys, there is cerebral edema. There's swelling of the brain. So if you give the solution, you may induce the herniation of the brain. That's why you should always provide diuretics. So you do diuretics as well as the saline solution. Now, adrenal insufficiency, something that we missed and you didn't remind me to say, it's the Waterhouse-Friderichsen syndrome. So Waterhouse-Friderichsen syndrome, that is the necrosis and hemorrhage. This is infarction, bleeding into the suprarenal or adrenal glands. And of course, if you have that, immediately it will lead to shock, because as you know, the catecholamines and the glucocorticosteroids, they maintain the blood pressure. So when there's no glucocorticoids, basically the person will collapse and go into shock. So that's why you need to provide glucocorticoids as well. So it's just to make sure that you, osmotic diuretics, you give mannitol. Yes, you give mannitol, and you give, eventually you switch, because mannitol is fast action. Then you go to furosemide, you change, okay? I also provide you with dosages in this presentation. So, so you go for and antibiotics, you want to make sure, remember we have the toxin is inside the cell, so we don't want to kill it immediately. What we want to do, we want to give bacteriostatic antibiotics and bactericidal antibiotics. That's why we usually combine together. For those purposes, you have cefotaxime or ceftriaxone, okay? And we also use the chloramphenicol succinate, okay? So you combine, usually it's the combined therapy of two antibiotics. Now, here's one thing that you also need to remember. You always need to make sure that you don't give the calcium-containing solutions with the ceftriaxone. And this is a typical mistake, because you always hear Ringer's lactate, right? And then as well, you have Ringer's lactate, and people are giving calcium-containing solution. Well, sorry, they're giving the ceftriaxone. This is a very typical mistake, especially in our hospital as well, just because people don't know this difference, okay? Because what happens, the calcium salt precipitations may be formed in the lungs and kidneys. So then after 5 years or so, you send the person to do the CT or to do the x-ray of the chest, and the person will be told by the radiologist, hey, you've been ill with a tuberculosis. You have calcifications here. But that's not because of that. The reason because of that, because once in their life, they were treated with these two medications together, okay? And this is iatrogenic. This is what you cause as a doctor. So please make sure you avoid doing those things. I'm sure you didn't know that, because most of the doctors at our hospital, they didn't know that as well. So what you also do, you do the antipyretic therapy, paracetamol, 10 to 15 milligrams. Now, remember, I told you about the lytic therapy, the antipyretic therapy. In this case, if you cannot, there's also paracetamol solution, which you can do intravenously as well. So this is actually a case where you would prefer to give liquid paracetamol to tablet paracetamol. Okay, this is the case. Anticonvulsant therapy, diazepam, Cetirizine, anything you have, you can give those. And immediately, of course, you want to do the transportation to the infectious diseases unit, because in infectious diseases hospital, you can why liquid is better? Okay. Excuse me. So why liquid is better? Because the patient may be unconscious, so there's no way you can actually give a tablet. That's one thing. Second thing is, if you give the whole dose of paracetamol immediately, it will act throughout some time. But if you give IV, it will constantly come in little by little by little dosages, so it will remain the fever low for longer time. I hope I make sense. Okay, good. All right. So, okay, sorry. Yeah. So there's another protocol. So there's one which you may have in the MCQ 737. Okay, the 737 again says that before admission, if the person is having meningitis, because previously it was meningococcemia. Okay, now we're having meningitis. You want to make sure you give glucocorticoids before admission. What is the reason behind it? Number one, you want to stop the production of the complement. Number two, you want to stop the hyperreactivity of the immune system, because once you kill the bacteria, you will increase the toxin. Okay? And finally, the third thing, why you want to do that? Because you want to decrease the DICS, the risks of DICS, and the risks of the occurrence of the Waterhouse-Friderichsen syndrome. So again, the same thing: antipyretics, anticonvulsants, and then usually for right now, actually, we're going back to benzyl penicillin. But again, be sure that the person has no allergies to that. By the way, it might be interesting for you, I guess, I hope. Indians, you can Google and see that the antibiotic allergy is very frequent in the Indian population. The reason why, because you consume a lot of antibiotics in general. So in this case, you want to make sure that you actually try and do the skin test first to see whether there's reaction to benzyl penicillin, because otherwise you may have hives and anaphylactic shock, and you will have to deal with that as well, which is not the best thing when you have an unconscious patient with meningitis. Again, the cephalosporins over here, and the dosages as well. You guys can keep this, and yeah, you can rely on these dosages, because this is the official guidelines and protocols of Ukraine. Okay, so these are the ones that you have to be indicating in your modules. Now, when you have, see, it says here, reserve in the absence of positive dynamics. Now, could someone explain to me, what does that mean? The absence of positive dynamics. Do you know? Anyone? Why would we go for meropenem or vancomycin? Drug don't give positive response. What do you mean by that? Resistant, of course, it's antibiotic resistance. That's why we would go, of course, yeah. That's why we would go for meropenem or vancomycin. Okay, now, and the detoxification therapy, that's basically the intravenous fluids. If you remember, I was telling you something in the lecture on GIT. I told you the geek solution, right? So this is what we would prefer to give now: glucose, saline, insulin solution. Why so? Because because you're losing a lot of sugar. The person is losing a lot of glucose, especially in the brain cells die and they require more glucose. Okay. All right, so let's see what we have here. Syndromatic treatment, symptomatic treatment. Well, these things you can go through yourselves. Okay, so I'm done with this. Now, if you would just yeah, okay. Is there any question that you don't understand so we can see? Okay. All right. Complement cascade. Okay. No. You're welcome. I will. Okay. Okay. All right. So let's have a look over here. The complement cascade, it has the alternative and the classical pathway. In the classical pathway, it binds to the immunoglobulin G. These are the immunoglobulins of previously carried out infection, well, in your life, right? So basically, for instance, let's say a person was ill with hepatitis A and eventually developed these immunoglobulins G towards hepatitis A. Okay, so now there is immunity to hepatitis A, which will bind to C2A and C4B. These proteins, along with the immunoglobulin G, will destroy the new coming viruses of hepatitis A. That's why you don't get ill anymore. Okay? Now, when the classical pathway doesn't work, and it doesn't in terms of Neisseria meningitis, because remember in the etiology, I said that the protein TRU and the opacification protein and the lipopolysaccharide and the cytoplasmic, the LPS and the capsule are helping to evade the typical immune response, and also the complement reaction, the reactivity. So that's why the C3 protein goes under the hydrolysis, loses blood, and creates C3b, C3a. The C3 fragment, C3b fragment, finds the protein. These proteins are produced by the liver. They're initially in your blood. They're circulating there forever, entire life, but they start this cascade only in certain cases. So then you have the C3b, which cleaves or cuts off the part of C5, C5a and C5b. Now the C5b, the C6, 7, 8, and 9 together will create a pore-like substance and will basically drain everything out from the cell. Okay? Was that clear? Okay, thank you. Now you can also see over here, you can also see that the pathway with the bacteria, there's alternative pathway, the classical pathway, which will all result in the activation. This is the CD59 pore, 5B to 59, okay, to C9. These proteins which will create the pore, see this is the pore, it goes inside the bacteria and kills it, leaves everything leaves out of the bacteria, okay? Okay, sir, please send the lecture. I will, if it's not too much trouble. Pathogenesis, okay. Okay, so bacteria, basically bacteria attaches to the mucosa, through the mucosa gets into the submucosal layer, That's where you have the blood vessels. From the blood vessels, it will travel around the body. If it reproduces in a huge quantities, it will end up as a meningococcemia or meningococcal sepsis. If the few of the bacteria will end up in the venous sinuses in the cranium, they will get through the hematoencephalic barrier. They will get inside into the subarachnoid tissue, creating colonies there. If you remember, hold on a second, I'll try to find that beautiful photo. Whoa, sorry. Wait a second. This photo right here, if you remember, so basically the pus underneath the dura mater will, and along with, of course, along with the increasing CSF, will cause the intracranial pressure, if you understand what I mean. Again, see the vessels over here. Hold on, how do I make this? This. Okay. Do you see how big they are? They're thick. So it means they're dilated. More plasma will come out of it. The more plasma comes out of it, the more pressure it is on the brain. Okay. Anything else? Sir, but you told this bacteria travel through veins, so how only brain damage and not other organs in initial phase? Wait, hold on. I told you there are two phases. One, development of meningococcemia. The other one is development of meningitis. It depends on the infectious dose. If it's very little, it will travel, end up in the brain, and then gets there and cause the meningitis. If it's a lot of it, it will end up in the multi-organ failure, sepsis, DICS, SIRS, and so on. Again, on the initial phase, it's only few of the bacteria, so the immune system might even kill them without the development of the disease. If you remember, I don't think you guys should be very attentive to what I say, because I keep on repeating over and over the same thing. If you remember, if you go all the way up to the classification, I told you that it may see major complications. The DICS, sepsis, it's the complication of the disease. But have a look. The localized form, localized only here. It doesn't go anywhere. Nasopharyngitis, sore throat and purulent discharge from the nose. Nothing else. It may go inside the bloodstream if it goes, but not necessarily. Be very attentive to what I say, because of course there could be generalized form, meningococcemia, or it can be the meningitis, depending how the bacteria will act, where it will go, and what it will do. Okay, very good. All right, well, I'm glad that you guys could learn something. Hopefully it was helpful for you. I will post this presentation, and yeah, you're welcome. Okay, so you guys have a good evening. It was nice having time with you. What? I can't hear. Text me. Unmute. Okay. Hold on. I wish I knew how to do that.
Thank you, sir.
You're unmuted. Wait, hold on a second. How do I do that? Okay, it's here, participant list. Yeah, you should.
Everyone can talk now.
Oh, thank you so much, sir.
Thank you, sir.
You're welcome.
Thank you, sir.
Thank you so much, sir.
You're welcome.
Thank you, sir.
Good night.
Thank you very much.
See you tomorrow. Bye-bye.
Good job, sir. Bye.